I'm going to start with a small topic. Perhaps it's a small point. It's phalangeal lengthening. We all know lower extremity lengthening is a standard procedure. It's done everywhere, every now and in every country. People do lower extremity lengthening. But if you talk about the upper extremity, we have very limited number in the literature of the upper extremity as a whole, not only the hand surgery. And perhaps most of the points I'm going to mention are published in 2020 in the Journal of Orthopedics and Traumatology by myself. And if any of you are interested in these topics, you can read this paper. It's open for everybody. So, in general, the indications for limb lengthening are controversial. In general, not only phalangeal lengthening, but all types, even the femoral lengthening, the humeral lengthening, forearm lengthening. The indications of lengthening have been extended from the lower limb length inequality to the upper extremity lengthening, including humeral, forearm, and phalangeal lengthening, with the humeral lengthening, forearm lengthening, and phalangeal lengthening. So we have upper extremity lengthening. The hand function. The power of the human hand depends on the length, strength, free lateral motion, and perfect mobility of the thumb. Amputation of the fingers, especially of the thumb, considerably affects hand functions such as pinch and grasp. So there's a functional problem if you have phalangeal shortening or phalangeal amputation. Traumatic hand shortening constitutes cosmetic and functional problem. It's not only cosmetic problem, because many people think that it's really, or it's purely cosmetic problem. This is not true. It's a functional and cosmetic problem. So functional reconstruction of an amputated finger differs depending on which finger is injured, level of injury, and patient expectations. Length of the finger is important for the function, for the stability, positioning, and space. Metacarpals were selected for lengthening due to their good vascular supply and adequate soft tissue coverage. What about the technique of lengthening, of phalangeal lengthening? We have different techniques. We have to do, one of them is to do osteotomy, acute distraction, and bone graft. So it's operative lengthening. This is acute lengthening. During the operation, you do the osteotomy, acute distraction, and you put a graft in between. The second method, which is more acceptable nowadays, is gradual distraction and bone grafting. That means you make an osteotomy, and you do gradual distraction for about perhaps 15 to half an hour during the operation, and then you put a bone graft. Nowadays, the distraction histogenesis is widely used also. So we have acute distraction and bone graft, gradual distraction and bone graft, or distraction histogenesis. It's difficult to achieve sufficient lengthening with these techniques, and acute lengthenings carry the risk of neurovascular complications. Like any other part, if you do acute lengthening, you can jeopardize the neurovascular bundle. Distraction osteogenesis is an alternative method by which greater lengthenings can be achieved with fewer number of complications. So you can have greater lengthening, because the extent of lengthening before was very short. Elizarov innovative procedure using distraction histogenesis is the mainstay of all newly developed methods of treatment. What does that mean? You have lengthening by external fixator or internal fixation, Every day there is a new method or a new tool to do the lengthening. But whatever the method, whatever the implant you use, all of them are based on the Elizarov biological law, the law of tension stress or distraction histogenesis. I'm going to show you my experience, 23 patients and 31 segments, because you will see in some patients we have 2 or 3 digits or metacarpals or phalanges for lengthening. The cases may be traumatic or congenital shortening. The age of patients starting from 10 to 36. Why 10? Why not younger? Because just we need a cooperative patients, but we can do it younger than this. 36, we can do it more than 36. There is no problem at all, but this is exactly what happened. And the level of osteotomy was metaphysis or diaphysis. And this is an example of delta finger, which is a congenital deformity, as you see on both sides, but we managed to treat the left side, you see. This is the delta finger. Oblique views. And we did corticotomy and gradual distraction, as you see here. You see, very good regenerate formation. And complete consolidation of the lengthening area, as you see here. Complete consolidation. The operative procedure. We published this operative procedure about, I think, 8 years ago. We use a rigid unilateral mini fixator, usually penic fixator. We used the Elizarov mini fixator in one case, but in most of the cases, all other cases, we used the rigid unilateral mini fixator, the penic fixator. We have 2 types, the L-shaped, as you see, the L-shaped type. This is, we used it in 90% of cases. 10% of cases, I will show you the other type. We use self-drilling, self-tapping screws, 1.8 or 1.6 millimeter diameter. So you don't have to do drilling or tapping or something. You go directly through the bone. Each set, you can introduce 4 half pins. 4 half pins. And this is the shape of the L-shaped, and this is the other type. This is the L-shaped type. We use it in 90%. Why we prefer the L-shaped type? Because it gives you a space to do your osteotomy. Because all your dissection, you have this area, not this small area. But if you use it here, it's only this area is available for you for dissection. So I prefer the L-shaped penic fixator. It's easier. It's easier also for the application than Elizarov. I'm not going to discuss how to do Elizarov with K-wire and you pin the K-wires. It takes such a longer time. Half pins are placed on the dorsolateral or the dorsomedial aspects of the bone. You can choose either one of them to avoid the injury to the extensor tendons. So in this case, we did phalangeal lengthening of both metacarpals. Here we introduced the half pins about 45 degrees dorsolateral, and here 45 degrees dorsomedial to avoid the extensor tendons. How we start? We start with the most proximal screw. Actually, I don't put a screw. I put a K-wire in the most distal part and another small K-wire in the most distal part. When I put the wires, now I can measure the length of the rod, because you know the fixator consists of 2 parts, 2 L-shaped parts. and you want to imagine the length of the rods. So when I put two wires, I can imagine the length of the rod. Then distally, we put another half pin or a wire. Now we can apply the rods of the fixator, the two parts of the fixator and the rod in between. You see that these are the two parts of the fixator. We start with the most distal, the most proximal, and the most distal. And then now we can measure the distance and you put the rod. And we can change the rod length. Usually we don't have nuts. It's not in the original description of this external fixator. But usually I put the nuts to keep this part stable or fix it, and I move it from here. This is the distractor. Why another nut here? Just to prevent the micro motion, which can be painful to the patient. So these three parts are not sold with the external fixator. I just added them for the stability. So after you put the most proximal and the most distal, you can add 2 or 3 half pins or 4, whatever you want, according to the situation. Because it's difficult to apply all these wires from the 45 degrees angle. It's not that easy as you imagine. So we complete the fixation by adding 2 or 1 half pin. 1 may be enough. Then we remove the rod to do the osteotomy in between. After fixation of the proximal part and fixation of the distal part, and you lock the screws. This is the site of locking. You lock the screws so there is no movement. Then you do the osteotomy in between, in this area. You make a small incision, and we use multiple drill holes by the tip of 1.6 millimeter K wire. I don't use the drill bit. I use the tip of 1.6 or 1.5 millimeter K wire for making multiple drill holes. Then with a very thin osteotome, I complete the osteotomy. After completion of the osteotomy, we reapply the rod, as you see here. We reapply the rod. After we reapply the rod, we do some distraction to be sure that the osteotomy is complete. So after application of the rod, you do distraction for 3 or 4 millimeters to be sure that this is the complete osteotomy. Then you close the wound afterwards. And this is the osteotomy or the corticotomy. And in such a case, we have only 2 pins proximally and 2 pins laterally. Sometimes you have a flap, a traumatic case, and you have a flap. And it is a good chance for the plastic surgeon to reduce the flap because, you know, the flap is raised. It looks ugly, so the plastic surgeon wants to reduce the flap. So he has to open here. So we used this incision to do the corticotomy. Unfortunately, in such a situation, there is massive soft tissue dissection, which is not good for bone lengthening, because you have massive dissection of this area, because he has to raise the whole flap again and reduce the flap and put it again. But anyhow, if he decides to do that, we are going to do our corticotomy or osteotomy from the same site. We don't do another incision. Sometimes it's not that easy. We don't have enough space to have stability. You know, if you want to have good regenerate, you need stability. But you have very small fragments to fix. it's not going to be stable. So this is an example. If we have this small fragment, we put two transverse half pins. You can put in this frame two transverse half pins. We can do another half pin in the metacarpal. We cross over the joint. So it increases the stability, but you have to remove this part earlier than that part. So if you have a problem with the fixation, because you have a small fragment, we do cross over the joint and we add another level of fixation, which is a temporary fixation, not till the end. Exactly like this case of delta finger also. You know, you have very small space here, just few millimeters. So we added another half pin and we crossed over the joint, you cross over. So if you have a limited space for fixation, you can cross over the joint and you add another level of fixation. The waiting period usually is 10 days. Not 3 or 4 or 5 days or 1 week. We learned that we have to wait at least for 10 days. The distraction started with the rate of 0.75 millimeter per day, 0.25 millimeter every 8 hours. But there is no rule. There's no rule at all. Each patient has his own merit. That means you need a close follow-up. Close follow-up after 2 or 3 weeks of distraction. If you don't see a regenerate, you have to decrease the rate 0.5 millimeter per day. If you still don't see a regenerate, you have to do compression. Compression and then start distraction again.
دكتور جمال في مشكلة؟
It's okay. The rate of distraction. Again, there is no rule at all. Don't listen to 1 millimeter per day or 3/4 per day. This is not true. It has to be modified according to the regenerate formation. And I'm going to give you this example. In this case, we lengthened simultaneously in the same stage the 2 fingers. But each one of them behaved completely in a different way from the other finger. The middle finger, we have very good regenerate. We even have, we started to have premature consolidation. So we increased the rate of distraction. You see there, to 1 millimeter per day, 1/4 millimeter every 6 hours. But on the other side, you see, for such a short distance, we have poor regenerate. So we minimized the lengthening up to 0.25 millimeter, 1/4 millimeter per day. Unfortunately, there was no improvement, so you have to do compression, then distraction, then compression 3 times. So even if you have concomitant lengthening of 2 digits or 2 metacarpals at the same time, don't think that they are going to behave the same way. In my experience, no, not at all. You have to deal with each one separately. So one of them can have very good regenerate, and another one has a poor regenerate, but there is no problem at all. Because whatever the behavior of the regenerate, you have to have very good consolidation at the end. So if you deal with the regenerate, you know, you modify your rate according to the regenerate formation, don't worry about the end results. The extent and rate of distraction. The rate of distraction in short bone lengthening depends only on the depends on the development of pain, sensory and vascular changes in the lengthened fingers. So, especially in the English literature, they like to put a limit for distraction. Even for the long bones, they put the limit 20% limit for distraction, because they have an experimental study on rabbits, and they said on rabbits, if you lengthen more than 20%, the rate of complications is higher. But we told them that we are not rabbits, by the way. It's not true. And because the number of lengthening or shortening as a whole in the West is very small, you cannot rely on most of their papers because they speak about very small number of cases. Why to bother about the extent? If you lengthen 0.5 millimeter per day, and you have a problem with the regenerative, you have pain, and you have sensory changes, you have vascular changes, you stop. So don't think about the extent, because you can have your own limits with follow-up of the patient. We don't think that the soft tissues around the metacarpals or the transverse carpal ligament has been influential on the magnitude of distraction, because also, again, the people, they talk about these obstacles, but usually it's hypothetical. What about if you have a very short stump? In cases with traumatic amputation with less than 1 centimeter stump, we recommend lengthening of the normal metacarpal. If you have less than 1 centimeter stump, it's very difficult to hold this part. And even if you hold it with the Elizarov mini fixator, it's not that stable. So we recommend lengthening of the normal metacarpal. We published that 8 years ago. And this is an example. If we have very small stump, and we lengthen the metacarpal, as you see here, to compensate for the shortening. The average lengthening in our hands is 22 millimeters, which is about 61% of the original length, which is more than acute lengthening or gradual lengthening and grafting. And at the end of the follow-up, we have no pain or functional impairment. Even the pinch power was improved and reached about 80% of the contralateral sides. And this is another example of phalangeal amputation. Again, we did lengthening of the phalanx with a short segment, and we did crossover, and you see the lengthening. Complications. We have pin track infection, and I will show you an example. One of them only had to remove one of the half pins in one case. The others needed antibiotics. Flexion deformity of the metacarpophalangeal joint, in 2 cases, which responds to physiotherapy afterwards. Premature consolidation of the regenerate. If you have premature consolidation of the regenerate, we don't take the patient to the operating theater again. We continue the distraction. When you build up the distraction, within a couple of weeks, the consolidation will break. You are going to have a closed fissure and sudden distraction, and the patient will have sharp pain. Such a case, and the patient have such pain, you close the gap again, and you wait for 3 or 4 days, and you start lengthening again. Poor regenerate formation, and I will show you how to deal with the poor regenerate formation. Now, because I would like to discuss the complications. If you work, you have complications, you have problems, and you have to show the people how you solved them. So, and this is the real experience. If we have multiple finger amputations, we can do them together or separately. In such case, we started with one metacarpal. You see corticotomy, gradual lengthening, poor regenerate formation. After 3 weeks, our diagnosis was poor regenerate formation, so we have to do compression. You see? Compression, distraction, compression, you see the bone formation, excellent bone formation. So this is a regular accordion tactic we use very frequently. And you see here the bone formation, excellent. This is the first finger. We'll go to the second finger, nothing happened. Very good regenerate formation in the same patient. So if you have experience in the same patient, don't expect to have the same results the second time. Again, in this case, we have a flap, and the flap was ugly, as you see here. So the plastic surgeon, and very short finger, the plastic surgeon decided to do reduction of the flap. So after dissection, he reduced the size of the flap, and we applied the frame from the posterolateral side, from the other side, not from that side, to avoid this incision. And we did corticotomy from below the flap and lengthening, gradual lengthening. Unfortunately, we have very poor regenerate formation. So we decided to do compression, distraction, compression. Unfortunately, the patient is not from Egypt, and he has to travel. So we decided to do a bone graft. This is the only case which required a bone graft. So we took the patient to the operating theater again, and the plastic surgeon did another session of reduction of the size of the flap, and we put a bone graft. So the iliac bone graft. In the same patient, we have deep infection of the half pin, this half pin. So we removed this half pin, and we put another half pin here. So we changed the frame also. It was a good chance, as the patient has general anesthesia, to remove this half pin and put another one. And you put an iliac crest graft here. But the patient went to his country, and they sent the x-rays, and with the follow-up x-rays, you see incorporation of the graft. But look to the other side, the bone, the regenerate started to develop on the other side. So this part from the distraction osteogenesis, and this part from the graft, incorporation of the graft. So هل احنا كنا متسرعين? So if you waited longer, would have been better if you waited longer to have the regenerate from the distraction osteogenesis? I don't know. But now, we have this. We doubled our assets, lengthening, incorporation from here, and incorporation from the distraction osteogenesis. You see the picture. This is distraction osteogenesis, and this is from the graft. And you see the end picture of the lengthening. Of course, the distraction at the end, because we took all the length of the distractor. This is the end of the length of the distractor. And this is, you see the end picture, short finger, and this is the end picture and the flap. Fracture, other complication is fracture of the regenerate. In this case, we lengthened one finger first. It's congenital amputation. You see corticotomy, lengthening. It's a huge lengthening. You see the lengthening area is a huge area. If you compare it to the original length, it's far more than 20%.
دكتور جمال بيه،
ايوه يا دكتور اشرف.
ساعة الباشا السلايدز مش بتتحرك يا فندم.
سلايدز مش بتتحرك؟ هرجع تاني كده بتتحرك؟
لا يا فندم.
خالد
المشكلة دي عندي انا بس.
خالد السلايد ما
دكتور
بتتحركش
جمال مع
عندك؟
حضرتك يا فندم.
السلايد
اتفضل.
بتتحرك ولا لا؟
دلوقتي ما بتتحركش يا دكتور.
لا ما بتدوس
كده.
نكست. كده
كده
اتحركت.
اتحرك يا دكتور اشرف؟
لا عندي ما اتحركتش.
لا اتحركت عندنا يا دكتور.
اتحركت يا دكتور.
اتحركت؟
طيب اوكي.
بتتحرك يا دكتور جمال.
طيب خلاص اوكي. يبقى انا هخش واخرج تاني معلش. اوكي.
بليز. I will wait for you يعني.
لا لا كمل بيك، عايز كمل ايه.
اوكي.
It's very interesting يعني بصراحة. It's very...
Thank you, Dr. Ashraf. Thank you. So we did corticotomy in one finger first, as you see, and lengthening. You see such a long distance. It's a huge distance, if you see here. Look to the distance. This is the first digit or the first, but we have a fissure here. We have a fissure. So this is a fracture of the regenerate. If you have a long distance, perhaps you are going to have in the middle fracture, but nothing happened. You put the patient in just a splint or something. After we finish this finger, we decided to do two fingers together, as you see here. You see the length in the middle finger and the length of the index finger. You see that length, this is a huge distance. And we didn't have any problem with this huge distance. But we have all the problems with the regenerate with this short distance. Unfortunately, we don't have an explanation. We don't have. We started the same operations, the same technique, and we have a longer distance here, shorter distance here, but we have to do many cycles of compression, distraction, compression in this digit to solve the problem. Let's solve it now to solve this problem of poor regenerate formation. As you see here, this is serial. You see the poor regenerate formation here. Very good regenerate formation on the middle fingers. What I want to say, you have to deal with each digit separately. Each digit has its own merit. Here it's a traumatic, almost excision of the half of the metacarpal. And we did corticotomy and lengthening, as you see here, for such a long distance. Again, we can compensate for such a long distance in such a traumatic case. In conclusion, because I think I passed the time, distraction lengthening is a valid option. I'm not saying that it is the only option. It's a valid option for phalangeal lengthening with relatively minor complications. Relatively, we have complications. For sure, we have complications. But also, the complications you can deal with. The complications did not affect the final outcome. We recommend osteotomy through the metaphysis because the results were better with the metaphysis. And we recommend distraction. We start the distraction as 0.75 millimeter per day or 0.25 millimeter each 8 hours. But you modify them totally. Most of the cases, we change them to 0.5 millimeter per day. Then we go to 0.25. Then we go for distraction. When we do distraction, we do it 2 millimeters per day. Then we wait after distraction for 4 days. And we start distraction again, and so on. The rate of distraction has to be modified according to the regenerate formation. Sorry. In cases with traumatic amputation through the proximal phalanx with a stump less than 1 centimeter, we recommend lengthening of the normal metacarpal. I think this is the end of it.